It is easier to give this talk than it was several years ago, I think, before we had an increasing array of options. We want to have more options for treatment, but we do have more options than we used to have. IgG4-related disease is usually not a difficult disease to treat. Most cases are pretty easy to treat, actually. There are exceptions to that. But it's usually more difficult to diagnose, as many of you have experienced. And then it is important when treating the disease, no matter what you're being treated with, to avoid the side effects. So that's the purpose of this talk. This is my agenda. I'm going to talk a lot about steroids, which are still the most common medication used to treat this disease, even in the United States, where we have more ready access to biologics. 85% of patients still get treated with steroids first. That's partly because they haven't been diagnosed and they get put on steroids while they're undergoing the diagnostic process. Then I'm going to talk about what we call DMARDs. I'll talk a little bit less about those. Molly just talked about DMARDs. These DMARDs stands for disease-modifying anti-rheumatic drugs. It's a very old abbreviation used in rheumatology. It includes things like mycophenolate mofetil and methotrexate and azathioprine. Then I'll talk about B-cell-directed therapies, and I'll talk about vaccines, which are very important for avoiding side effects of therapy. So first of all, to steroids. These three gentlemen shared the Nobel Prize in Physiology or Medicine in 1950. The guys on either side, Kendall and Hench, were at the Mayo Clinic. Mayo Clinic is famous for many things, but I think probably the biggest is these guys' work in the discovery of the therapeutic use of cortisone to treat inflammatory disease. They shared the prize with Tadeusz Reichstein from the University of Basel in Switzerland. And it truly was a great moment in history. And we've been recovering from it ever since. So what do I tell patients about steroids? The first is that these are truly among the most remarkable medications invented. And I wouldn't be a rheumatologist if it were not for steroids, because it would have been hopeless when I went into rheumatology to try to treat patients without steroids. But we are trying to get away from them now completely as fast as we can. So they're the most miraculous medication for 24 to 48 hours. And then some of the side effects, which many of you know and I will talk about, begin. They're often necessary to control dangerous inflammation. Quickly, there's nothing that treats inflammation more quickly than steroids. So thank goodness we have them. But they have to be used carefully. So these are some of the many things that I tell patients about steroids. One of the challenges that clinicians have is that they don't have enough time to tell the patients fully, to inform the patients fully about the different complications that may happen on steroids, because there are so many of them. But I also tell patients that we must try to stop them completely as soon as possible. And IgG4-related disease is a disease that I really think we can get away from steroids completely. The issue is going to be access to therapies. We already have therapies that are better than steroids. The issue is access to them, and that's going to continue to be a challenge in the future, I suspect. But IgG4-related disease is among a host of diseases for which steroids remain the cornerstone of therapy. It is kind of an astonishing statistic, but there are 50 million chronic steroid users in the world. And this is not inhaled steroids or topical steroids. It is systemic steroids taken by mouth every day for all of these conditions. So I also tell patients that steroids affect every cell in the body. That's because the distribution of the steroid receptor is on almost every cell in the body. So we give a treatment to target certain cells, a limited number of cells in the immune system that are causing the problem, But the treatment, when we give steroids, also hits not only the B cells and the T cells and the other cells of the immune system, but the bone cells, the skin cells, the brain cells, the intestinal cells, every cell in the body almost. This picture really underscores so many of the toxicities. This young man had been on steroids for 2 years before I saw him. And you can see he had a very full face. It's referred to as a moon face. He had gained 75 pounds over the course of 2 years. He had gone from weighing 150 pounds to 225 pounds. He has acne. He has hair growth that he wasn't particularly happy about. All of these are side effects of steroids that one can see. And the ironic thing is that he was on all of that steroid to treat inflammation only in one of his eyes. He had inflammation around the extraocular muscles of the left eye, which is on the right side of the picture there. You can see his eyes are a little bit asymmetric because he had inflammation around this, in the small muscles of that left eye. And he was absorbing all of this systemic toxicity to treat this very limited inflammation. So that's one face of steroid toxicity, but because the steroid receptor is on so many different cells in the body, steroid toxicity actually has many faces. And this is only a partial list of the different side effects that can happen when patients are treated with steroids. And many of these are major, serious, life-threatening, and even fatal complications. So if used improperly, I tell patients, the effects of steroids are fearsome, and everything that was on that previous slide underscores that point. And I love this expression that they have in China, and Wen Zhang shared it with me. We were talking about steroids on a podcast that we did called From Boston to Beijing, and she said, we have a saying in China to turn pale at the mention of a tiger. And this is the response that many patients have in China and in Boston when they are told, we need to put you on steroids. They've heard a lot about steroids, and they turn pale at this idea. So that's a wonderful, apt expression. The reason I gave the microphone to Professor Zhang is I wanted to ask her to comment on this wonderful symbol of the Chinese IgG4-related disease collaboration group. Could you just explain, Wendy, what this means?
Thank you, John. I didn't expect. Okay, so this is the Chinese collaborating group of IgG4. We use this whole structure is like Chinese knot, right?
Knot.
Knot.
K-N-O-T, knot.
Yes.
Yeah.
And it composed of 4 IgG structure. If you look at the detail, each IgG has 2 different colors. Because our IgG4 has the special structure different from other IgG subsets, we can call it FAB exchange. It always exchanges, so they have different structure. So this is the outside, and the inside is the heart. The heart also has different color, means we collaborate together with doctor and doctor, and also we collaborate with doctor and patients. And in the inside, it's a victory. So with the collaboration between doctors and with patients, we will get victory. Thank you.
That's wonderful. Thank you. I just love that, and thank you. Sorry for frightening you, but that was great.
Yeah. I should prepare.
You
you told me before, I will prepare.
You almost turned pale, like the thought of a tiger.
I turned pale. Thank you.
So the tolerability of prednisone, some general rules of thumb. First of all, it's a ticking time bomb. You hand the patient prednisone, it's a ticking time bomb. And the bomb is going to go off faster the higher the dose. But 10 milligrams a day is really not tolerated well by any patient over a significant amount of time. No matter how young and fit they are when they start, 10 milligrams of prednisone, they're going to have side effects sooner or later. 6 to 10 milligrams of prednisone a day is tolerated very poorly by many, particularly anybody with any kind of predisposition. If they're already hypertensive or inclined toward diabetes or have osteoporosis, they're not going to fare well on that dose. We've thought for a long time that maybe 5 milligrams a day or less is okay in the right patient, but we're really now rethinking that. And I think it's reasonable to believe that there's not a safe dose of prednisone for bones, for example. There is no safe dose. It's also important for those of us in this room to realize that people living with IgG4-related disease, many of them are predisposed to doing poorly on prednisone. This is because the disease tends to affect middle-aged to elderly people. The mean age at diagnosis is 58. That means that half of the population is older than 58. We have a lot of patients with IgG4-related disease who are 70 and older, and they may already have a lot of potential complications that would make them do poorly on steroids. Pancreatic damage, as other speakers have indicated, is very important in IgG4-related disease. Here's a classic sausage-shaped pancreas of IgG4-related autoimmune pancreatitis, and if the pancreas is inflamed, it's not going to be as good at making insulin, which is essential to maintaining normal blood sugars. So patients are going to be more inclined to develop diabetes. And we found in our cohort at MGH that 80% of the patients with pancreatic involvement have permanent pancreatic injury, underscoring the importance of earlier diagnosis. Osteoporosis is another problem, and I think it's something that we need to pay more attention to as a community. Our patients really are susceptible to osteoporosis more than others, and we need to write about that and think about that more. So these are the common complications of steroids that you can see on the skin: easy bruising, skin tears, a candida infection in the mouth or thrush, excessive hair growth. I love this slide. I used it yesterday too in another context. Those are the side effects of steroids that you can see. Many of the side effects of steroids are subclinical. So you might be able to see the skin changes, but you don't see the osteoporosis, the bone fracture until it happens, the joint necrosis until it happens, and so on. So you may believe that the patient's okay on 5 milligrams of prednisone a day, but there may be changes that are happening that will eventually prove that not to be true. So what do doctors think about steroids? Variety of things. Not all doctors are alike, but many doctors think that there is a golden dose for the patient that will control the disease. There's a golden dose that I can find that will control the patient's disease, and the patient will do really well. And many also think that steroids have side effects, they're a necessary evil, but I know how to use them. And both of those statements are wrong. The therapeutic window is too narrow for steroids. Any patient is going to have steroids eventually, no matter who is going to have side effects, no matter who their doctor is. This is really important. Steroids work so well in IgG4-related disease and many other conditions. I sometimes describe it to the patient: steroids work so well, if you just unscrew the cap of the bottle, you start to get better. But they work wonderfully to control the disease in high doses, but they fail patients over time, almost all the time. As we try to get patients off steroids or get them off completely, they almost always flare eventually, and that's true for many diseases. This was shown in a study from Japan. It was a year-long study of steroids only. Patients were put on only steroids, Every single patient responded to steroids, and patients were not taken off steroids completely. The median dose at the end of the study was 7 milligrams a day, so too much for many patients. Despite a year-long course of steroids, only 60% of patients were in complete remission after being on steroids for a whole year. So steroids didn't control the disease in a great number of patients, despite the fact that they were maintained. 41% of the patients had glucose intolerance. 20% of these patients had new onset glucose intolerance. There were serious infections in 18% of the patients and other steroid complications as well. So steroids eventually fail most patients, and that's something I don't think most doctors understand. The question of is there a safe dose, I think, is informed by this study, which was performed in rheumatoid arthritis, looking at a couple of very large healthcare data sets in the United States. The investigators asked the question, does chronic low-dose steroids increase risk of infection? And this was one cohort. This was a Medicare cohort of patients. And what it demonstrates is that patients on less than 5 milligrams of prednisone a day, less than 5 milligrams a day, 11% of the patients were hospitalized for an infection. Not just an increased predisposition to colds, they were hospitalized for infection on less than 5 milligrams a day. In the other cohort, which is a younger cohort of patients, the optimum database, 5% of those patients were hospitalized for infection. What else do I tell patients about steroids? I tell them, work with your doctor or work with me to discontinue them entirely as soon as you can. We can do this in IgG4-related disease. We can get patients off steroids completely. We now have treatments that are safer and better than steroids. And it is very rewarding to everyone to do this. This was the young man when I met him, and after we had finally gotten him on an effective therapy, he had gone back to Oklahoma, and I was doing a Zoom follow-up with him. He was in his car, and I took this picture of him with his permission, and you wouldn't recognize the patient. He's changed completely, and you can tell he's pretty happy compared to the way he was the day I met him. So the foundation can help with steroids and steroid complications, and recently we've provided access to a program called Steroids and Me, or SAM. There is a banner out in the hall about this. There's some enclosures in your bags about Steroids and Me, and it is an app that allows patients to read about, understand steroids, and optimize their use. We'll shortly have a link to SAM on our website, so anyone can join. It is offered free for patients. So the different side effects one can read about here. Steroids and sleep, for example. Insomnia is a big problem for patients on steroids. We have key opinion leaders such as Dr. Jane McDowell, who is a pulmonologist in the UK, talking about how to manage sleep issues. We have Michelle Petrie, who is one of the world's leading lupus experts, talking about the impact of steroids on mental health. I am there talking about how to talk to your doctor about steroids. That's a conversation that a lot of patients find difficult to do. I'll give you some tips on that. And I come to wrap up steroids, I come back to what Dr. Murray Urowitz said. Dr. Urowitz is a famous lupus rheumatologist in Canada. He says, if you ask the doctor and the patient what they want most of all, their unanimous answer will be not to have to use steroids. So I look forward to moving past steroids in the near future for this disease. Let's turn quickly to DMARDs. I will talk less about those. It's a big topic, and so I'm going to be very concise. The DMARDs that I will just mention would be mycophenolate mofetil or Cellcept, methotrexate, azathioprine, and aflunomide. And I'll start by telling the story of this patient of mine whom I took care of a long time ago now. And he had a different disease. He didn't have IgG4-related disease. And I had him on methotrexate to treat this disease. His underlying disease, which was granulomatosis with polyangiitis or ANCA-associated vasculitis, affects the kidneys. And over time, his kidney function worsened. And one thing that's important to keep in mind with methotrexate is you've got to adjust the dose if the kidney function is worsening. And I didn't adjust the dose because it sneaked up on me, and he broke out with shingles with a zoster infection. So I switched him to another medication, azathioprine. And I didn't realize, because the world was waking up to the fact that when you use azathioprine, it's important to check if the patient can tolerate the medication on the basis of genes. And there's an enzyme called thiopurine methyltransferase, which is encoded by our genes. And there are two alleles, and if you have both of them, you have no trouble metabolizing azathioprine. If you have one of them, you'll probably do okay. But if you're the 1 in 300 who doesn't have either one of them, you can't metabolize azathioprine. And the bone marrow takes a big hit. And this patient's bone marrow took a big hit. Complete bone marrow shutdown for a month. He was in the hospital. I certainly thought he was going to die. Fortunately, he didn't. We were able to support him, and here he is as his bone marrow is starting to come back. He still has drips that are going in his vein. Maybe this is a platelet transfusion, I don't know. But it was a very difficult time. So I tell this story to underscore the point that these medications are not candy. They have individual side effects that one needs to be aware of. A wonderful clinical trial done in China actually demonstrated that these therapies do have steroid-sparing effects. They should be used for the purpose of reducing steroids. We've, until this study, really had rather little evidence that they actually reduce steroid side effects. But this study had patients in 3 groups. The blue curve shows the patients who were stopped both their steroids and their DMARDs, and you can see the downsloping curve indicates the high flare rate in that group. Patients who were maintained on their DMARD or who were maintained on both steroids and DMARDs were the 2 top curves, and they had a flare rate that was about the same. The conclusion is that it is possible to get patients off steroids completely if you use these disease-modifying anti-rheumatic drugs. So avoiding the side effects of DMARDs, understand the disease-specific effects. Each of them has different ones. Monitoring needs to be done through routine blood work, nothing fancy, but it's important to get it done regularly. And you can get that done while you're having your IgG4-related disease blood tests done. It's important to identify the effective dose, and don't use these medications if they're not actually helping get you off steroids completely. If you're still not able to get off steroids completely and have to take these medications, another approach is needed. So I'll switch now to B-cell-directed therapies. We've talked about B-cell depletion. I'll talk a little bit more about what that means with strategies designed to target CD20, a marker on B cells, or CD19, another marker on B cells, rituximab or inebilizumab. There are other B-cell depleting approaches, but these are the ones we've used most commonly in IgG4-related disease. We hopefully will have the ability to suppress B-cell function rather than to completely deplete B cells in the next 18 to 24 months following the completion of the obexelimab trial, which is going on now. So what do I tell patients about B-cell targeted therapies? I tell them that these drugs are safer and more effective than steroids and DMARDs. And I absolutely believe that. There's no question in my mind. They are safer and more effective than steroids. But they have to be used wisely. So what side effects do I tell patients about? It's a lot to inform patients of their diagnosis and tell them that they don't have cancer and to tell them that they're going to have to receive an infusion now if I'm going to use a B-cell depleting approach. I tell them about infusion reactions. Minor infusion reactions are very common, and they're over with by the time the infusion is completed, typically. Rarely, meaning 1 in 1,000 maybe, patients can have anaphylaxis, which is a life-threatening infusion reaction. We try to prevent that by giving some steroids at the beginning and Tylenol and Benadryl. But I do mention the likelihood that they will have a minor infusion reaction because that occurs pretty frequently. Serum sickness is when the patient's immune system develops antibodies to the drug. I've only seen this one time, maybe 2 times. It's pretty dramatic when one sees it. It happens after the second infusion, often during the second infusion. The patient has made antibodies to the drug after the first infusion, and the immune system sees the drug again, and bang, immune complexes are formed, and these immune complexes circulate in the body, deposit in the very small blood vessels, and you have a rash that looks like this. It deposits in joints as well, so patients typically have a very painful arthritis. This goes away as soon as these immune complexes resolve. But patients can't be retreated with that same drug if this has happened. Reactivation of hepatitis B. It's not an issue for most patients. Most patients don't have hepatitis B that is dormant, but a significant number of patients have acquired hepatitis B, very often at birth, from their mother. And they don't even know that they have hepatitis B. It's important to check for hepatitis B before starting B-cell targeted therapy. And one does this by measuring antibodies in the blood directed against hepatitis B core antigen. If a patient has these antibodies, then they need to be treated to eliminate, essentially, the likelihood that hepatitis B will flare up. There's very good medication to do this, but you have to check first. So I talk with patients about this. What does B-cell depletion mean? I think that's an important question to address. So when we deplete, we say B-cell depletion, that means that the B cells are no longer detectable in the peripheral blood. And they're no longer detectable in the peripheral blood, usually just a few days after a B-cell depleting therapy is administered. The body is not completely depleted of B cells. B cells remain in the lymph nodes and the liver and spleen, but they're not measurable in the peripheral blood. At least that is the case with our conventional B-cell depleting agents. So I think about it like this. Here's a B cell with CD19 or CD20 or both. Most B cells have both of these markers. And the B cells are becoming plasmablasts. Dr. Perugino talked about this a bit yesterday. The plasmablasts are among the B cells that produce much of the IgG4. These plasmablasts are doing what they do all the time. They go away all the time. They're short-lived cells. And that's okay in terms of IgG4 production as long as the B cells are there to continue to differentiate again into plasmablasts. So the plasmablasts supply is maintained and the IgG4 is maintained. But if the B cells are depleted because of a B cell depleting agent, there's nothing to sustain these plasmablasts, and then the IgG4 concentration falls, as Dr. Carruthers mentioned, by 50% or maybe even more over time if repeated B-cell therapies are given. When those B cells are starting to come back, and this is a quite rare complication of B-cell depletion therapy, but it happened to one of my patients about a month ago, the bone marrow can sort of get confused and stop making other white blood cells, other neutrophils. And the condition of neutropenia happens, low white blood cell count, 0 white blood cells. And in this setting, the patients can have fevers, they're at risk for infection, but it lasts only about a week, and usually by the time it's diagnosed, they have a fever, they see their doctor, they're found they have 0 white blood cells. Usually the condition is already resolving. The B cell the bone marrow is starting to make more white blood cells. So I usually don't mention this complication to patients because it's such a rare thing. But it does happen in some patients. It's happened to 2 or 3 of my patients out of probably 1,000 that I've treated with B-cell depletion. B-cell depletion can be used again in this setting, so it does not preclude retreatment in the future with B-cell depletion. Shingles can happen in B-cell depletion therapies. This can be prevented by making sure that the patient is vaccinated beforehand. So I repeat, although there are potential complications of B-cell depletion therapies and B-cell targeted therapies, these drugs, I believe, are safer and more effective than steroids and DMARDs. So I want to turn to COVID, because COVID gave us a rude awakening about the potential dangers of B-cell depletion strategies. Patients on B-cell depletion strategies are at greater risk for poor COVID outcomes. Full stop. There's no question about it. Out of all the immunosuppressive medications we use, B-cell depletion treated patients fare the worst if they get COVID. So here's where vaccines come in. So in August, we did a fireside chat with Dr. Camille Cotton, an infectious disease expert at MGH, Viruses and Vaccines. This fireside chat is available on our website. I encourage you to go and watch it. If you haven't, watch it again. If you heard it live the first time. Camille thinks about these issues all day, day in, day out, and she gives some wonderful wisdom about this. But first, just to COVID vaccines and their importance. So these data are from a very recent period, from October 2023 to until this past March, and the data describe the patients hospitalized with COVID. Patients still get hospitalized with COVID, they still die with COVID. If you were aged 18 to 49 during this period and got hospitalized for COVID, it was a very small percentage of patients, 3%, who had been vaccinated that year. That's the little green bar. The large yellow bar is the 78% who had not been vaccinated. As patients get a little bit older, you still see that green bar very, very low. If patients have been vaccinated, they comprised a very small proportion of the patients who were hospitalized with COVID. And the same is true for this age group, and it's creeping up a little bit as patients get older. But this really underscores for me the importance of getting vaccinated. There was a wonderful editorial by Dr. Francis Collins, who was the head of the NIH under 3 American presidents, George Bush, Barack Obama, and Donald Trump. And he presided over the COVID era, and he called the mRNA vaccines one of the greatest medical discoveries ever. And he's absolutely right, how fast this was done. The effectiveness of these vaccines, 90 to 95% effective, and close to 100% effective at preventing the severe respiratory disease and death. It has been estimated by the Commonwealth Fund, which is a nonprofit group that does healthcare studies, that more than 3 million lives in the United States were saved by these vaccines. And Dr. Collins noted, if you were vaccinated, you might be one of them. But he bemoaned the fact that there were more than 50 million adult Americans who declined to be vaccinated, even though it was free. 50 million. The Kaiser Family Foundation, another nonprofit, estimated that 230,000 Americans died unnecessarily in this time. 230,000. That's the equivalent of 4 very big airplanes crashing every day in the United States. And Collins notes that this is largely because of misinformation that caused patients to be scared about getting vaccinated when, in fact, vaccination might have saved them. This is very important for the IgG4-related disease community because many of us are at greater risk because of our treatments for this disease. So the IgG4 mission statement, which Henry noted that I say every time I talk, is to enhance the lives of people living with IgG4-related disease through education, awareness, and research, and to serve as a trusted source of truth about this disease. And we will continue to hammer on this message when it comes to vaccines. So key points about vaccines: none of the COVID vaccines is a live vaccine, none of them. These vaccines are remarkably safe. They do not cause IgG4-related disease or any other autoimmune disease. They reduce the risk of long COVID, which is another reason to get vaccinated. So the vaccines for people living with IgG4-related disease are important. Flu shot every year, COVID shot once a year for most people, maybe more for patients on B-cell depletion, pneumonia shot, shingles vaccine, and for individuals aged 60 or over at risk for complications, and that would include patients on rituximab or other immunosuppressives, the RSV vaccine. So these 5 are ones that one should think about. Using the vaccines properly, and this is really critical, one should be vaccinated before getting treated. Ideally, you get vaccinated and then start steroids, or then get B-cell depletion, or then start a DMARD. The vaccine will be most effective if you have been vaccinated before starting treatment. You can get more than 1 vaccine in a single day, so that's important to remember. You need to allow 2 to 4 weeks after getting vaccinated before starting treatment. If it's necessary to be treated before getting vaccinated, one can start relatively small doses of prednisone, 15, maybe 20 milligrams a day if necessary, and you can probably still have a good vaccine response, although it's good not to have any if you can avoid that. And for patients on continuous B-cell depletion therapy, and some patients with IgG4-related disease it's important to think about revaccinating. And this is one of the things that I really learned from Dr. Cotton's presentation. If you have been on continual B-cell depletion, have no B-cells, you should still get vaccinated. And you should probably get a booster again every 6 months. Very important point. So most patients should get COVID vaccines once a year, and many may benefit from revaccination every 6 months. Finally, if you get sick, get treated. Full stop. There's no question. Should you receive COVID therapy if you get sick? Yes, you should. And don't wait for things to get really bad. Get treated early. So I'll stop there, and thank you very much for your attention, and close with this very happy photograph. So we're a little bit over time, but I'd be happy to take a question or two if there are a question or two, and if not, we will go. Okay, yes,
Hi.
Lisa.
Thank you very much for having all of these wonderful medical professionals here, including yourself, for this with patients, because being able to get educated and exposed to this kind of information is really important, so thank you. My question was, you show that rituximab has an effect on CD19, but you also show CD20 and another B-cell depleter that works on that. What is the difference, and why would it be important to also affect the CD20?
So rituximab, which is the drug that we've been using off-label for about almost 15 years now, whenever we can get it, targets CD20, which is one marker on B-cell. There is another marker, CD19, which is also on the B-cell, and we'll have to have some more education around this, but most B-cells during their development have both of these markers. CD19 is on B-cells for a little bit longer than CD20 is. So if one is targeting CD20, or one is targeting CD19, in theory, you might deplete more of the B-cell pool, because more B-cells have CD19 than CD20. In fact, both of these treatment approaches work quite well for depleting. It's not clear that there's a difference, but there may be, certainly. So they'll both be options. There are differences. Rituximab is what we call a chimeric antibody. It's made using not only human amino acids, but mouse amino acids. And these mouse amino acids can lead to a greater likelihood of infusion reactions and antibody development against the drug. The CD19 therapy, inebilizumab, which you'll hear more about this coming week, is a fully humanized antibody. So it's not made using any mouse amino acids. So it is probably better tolerated in terms of infusion reactions, but that remains to be proven. Yes?
Hi. One of the vaccines I didn't see up there was whooping cough. Can you take that?
Whooping cough. Does anyone know if that is a live vaccine? No? I can't remember. So there are some vaccines. Measles, mumps, rubella, MMR is a live vaccine, so one has to be careful about that one. But I don't remember about whooping cough. It's a good question. You don't think it's a live vaccine? Okay. So yeah, that shouldn't be a problem. Yeah.
Yeah, I have a question. So like when the infusion no longer works, like in my case, what would be the next step?
If an infusion no longer works.
Yeah.
So we should have a longer discussion. I'm happy to do it during one of the breaks about what the particular manifestations are. And Dr. Katz talked about if therapy doesn't seem to be working, whether it's prednisone or an infusion, is it damage that's not responding, or is it actually disease, inflammation that's really refractory? That's a very important distinction to make. But if you do have a manifestation that is refractory to a B-cell depletion strategy, then I might think about adding a DMARD, like MMF, would be probably the one I choose. If necessary, the lowest dose of prednisone possible. So I think that would be probably the treatment strategy. But we should talk further about what the specifics are about your case. Thanks for the question. Any other questions? Yes.
Hi. So my question would be, if you're not on Rituxan yet, or that's in your possible near future, or if you're already on Rituxan, if and when this other new study, if it should get approved, are you able to remove the Rituxan to move on to a different type of infusion therapy? And the other thing that you didn't touch upon, and I don't know if you will later, is could IgG4 or any one of these autoimmune diseases be caused by environmental issues?
Okay. So the first question, if you've been on rituximab before, could you receive inebilizumab? The answer is absolutely yes. Yes. I wouldn't expect that there would be any problem there. A lot of patients may want to make that switch. The ability to do that's probably going to be dictated by coverage issues, and that's where the access question comes in.
Okay.
Could IgG4-related disease be caused by environmental issues? Absolutely. That's that has been one of the theories that has circulated for some time now. It's always a difficult thing to pin down, though, because we're all exposed to the same environment. There are some, if you work in a factory that has asbestos, that's a little bit different from working in a hospital that hopefully doesn't have asbestos. But it's hard to pin down particularly which environmental exposure might be causing things. And it's probably on some genetic background and maybe other factors through which environmental issues could contribute.
Okay, thank you.
Thank you.